again for having us. We have Mike in the room, Mike Sinig, and Suki, who's our nurse, and Dr. Runback, of course, and Dr. Patel at the wrist access. So this is a 57-year-old gentleman with a history of hypertension, sleep apnea, and obesity. He presented to the emergency room after 3 days' history of severe sudden onset left upper quadrant pain. It was worse during inspiration, and it did radiate to his shoulder, left shoulder. Next slide. Again, history of cardiomyopathy, a negative cardiac cath recently, non-ischemic left bundle branch block, a renal insufficiency, and an echo of LVF of 40%. And at the time in the emergency room, an abdominal CT scan was performed, which showed a splenic infarction, as well as a 2.5 centimeter celiac artery aneurysm. Next slide. Here are pictures from the CT scan. You could see the splenic infarct is a nice, almost wedge-shaped defect, hypodensity in the spleen. Next slide. And you can see here the axial CT scan at the level of the celiac artery showing the area of abnormality, specifically the celiac artery aneurysm at its origin, extending to just up to the confluence of the splenic and common hepatic arteries. Next slide.
Let me know you.
Here are maximum intensity projection images reconstructed. On the left, you could see the superior mesenteric artery and its normal course, and just superior to that, the celiac artery and the aneurysm. Next slide. So the plan here is both for left radial and left femoral access. I think normally we might perform a right femoral access, but in this case, because of the constraints with the camera, we're going left side on both, left wrist, which is the usual, and left groin. We're going to probably use the morph sheath, which we have now in the left groin, a 6 French morph sheath. And we're going to try to both wire the splenic and hepatic arteries in order to perform our procedure. The plan is to coil in the proximal and mid-splenic artery. We're going to probably use interlock coils for that. And we're going to try to exclude the aneurysm by stenting into the common hepatic artery from the celiac axis using a combination of Gore-Viabon and possibly ICAST stent as well.
All right, so I'm going to let Dr. Herman take over in a minute. It's just what we've done is working from the radial axis. Dr. Patel has gotten a wire out into the splenic. Oh, he's going to be getting a wire out of the splenic. And I'm going to try to go more lateral. Well, I'll go AP for the moment. And obviously, through the morph catheter, I'm not sure if that's seated well enough. We have a wire out into the hepatic. So let's just get an initial view here, just an additional angiogram. And our goal is going to be to work from the top and coil that proximal to mid-splenic, as you saw. Looking at the anatomy of this, you have to turn off the injector. Looking at the anatomy of this, I think that we are going to need every millimeter of that celiac. So when we do the intervention, we'll go lateral, but we sort of started AP here. If we can play that back. Oh, and thank you. Sorry, I just have to cover this up. We were rushing to get ready, so I apologize for these minimal delays.
Now, while you're getting that ready, Michael, from vascular medicine standpoint, this one has a clear-cut indication because of splenic infarct. If there's no infarction and no symptoms, when do you treat celiac aneurysms?
So the issue here is that if a patient goes to an outlying hospital and presents with abdominal pain and doesn't know that they have this or doesn't get it followed closely, by the time somebody figures it out, they're dead. So we generally think 2 centimeters is the cutoff.
Get the artery in the splenic.
I think the interesting part of this case, from a non-technical standpoint,
I need a 100 centimeter non-taper angle.
There's a bunch of things running through my head, but I wonder if John's kind of a closet vascular medicine geek. I hate to tell you all that, but I wonder, John, what you thought was the cause of this.
You know something, if you looked at this, I think there was a dissecting component to this. And although he has no prior history, and we did the homocysteine Ehlers-Danlos workup, I don't wonder if this wasn't some sort of form thrust of SAM, you know?
Yeah.
Because, you know, I sort of saw a little dissection component and then the aneurysmal component, and that would also explain the acuity of his presentation, right?
Yeah, so John's suggesting segmental arterial medialysis, which is a really kind of unusual some people think a seventh form of fibromuscular dysplasia. But, you know, the other thing this could be, I'm presuming there's not a red blood cell in the urine, John?
Not a red blood cell in the urine.
Yeah, right. So Peter and I were whispering about polyarteritis nodosa as another potential weirdness for this, but that'd be a little hard to believe with that with no blood in the urine.
Yeah.
So is Peter a closet vascular medicine guy as well?
He's right out there. Schneider's right out there.
That's why I was whispering about it. Michael outed me.
So while they're working from the radial access to get out into that splenic artery, I'm working through this morph, as you can see, to try to get a glide catheter out into the hepatic artery where we're going to secure a V18 or Platinum Plus wire so that we can eventually park probably a Viabon. So we want to get a lot of room out there.
Yes, mag up. I'll take that second for Mike.
What is the usual celiac trunk that you're going to stent? And you know, you're going to use a covered stent. Do you have an adequate landing zone
Yes.
before the
Yeah.
bifurcation, the splenic and hepatic?
Well, what we're actually going to try to do, and this is why I personally like the Viabon in this, is you saw there was a big mismatch between a 7 or so millimeter common hepatic and then, of course, this aneurysm. But I'm presuming the ostium of this celiac is going to be, 7 to 8. So my plan was to coil the splenic and then extend the Viabon into the common hepatic. Now, there is a little left gastric there that we see. We're sort of going to keep an eye on that. I'm not going to coil that right now. If need be, we can always come via right gastric. We do that fairly commonly in the setting of some of our cancer interventions, so we're comfortable with it. But I don't think at this setting we're going to necessarily treat that left gastric. Again, we're not so much worried about the size of the aneurysm. We're worried more about embolic risk and progressive dissection in this particular instance. Let's get a Platinum Plus, please.
Peter, one of our surgical colleagues, what do you think the sequelae is? There any consequence you expect when you coil the splenic
Mag up one.
artery here?
Well, I think
Back up one.
he's going to have pain when you do it.
Yeah.
I mean, he already had pain from his first, small splenic infarct. But I mean, this is something that we do routinely. Just make sure he's got a pneumovax, and if he had a big splenic artery aneurysm, you would take it. Typically, the spleen, or at least some of it, does stay alive from the short gastrics. And it's not, we don't typically think of it as significant. The challenge here will be how to get a covered stent in there without affecting flow in the left gastric, and that's always a challenge. I mean, this is a dynamic area. The crus of the diaphragm is, kind of a compressive structure here, the same way we talked about earlier, compressive structures of the veins, this is an anatomical compressive structure, and typically you get a dilation of the artery just beyond where the crus crosses it. So if you put some, he's probably going to have to, I'm imagining he's going to have to reinforce the Viabon with a stent, or at least that's typically the way I would do it in this position. SMA plus minus, but celiac usually I would reinforce.
You bring up some good points there, Peter. So first of all, I'm not too worried about a splenic infarct. We have a lot of experience in the trauma setting doing proximal splenic artery coil embolization, and you get dorsal pancreatic, pancreatic magna, short gastrics, right to left gastrepiploic. So generally you preserve splenic viability and opsonization. So I'm not too worried about that. Left gastric, I'm more worried about backwards filling. Again, we have experience prophylactically embolizing left gastric, and very interestingly, in the bariatric setting now, there's an interest in doing this to reduce the production of ghrelin and cause early satiety. So including that doesn't worry me so much. I'm a little worried about the size mismatch, though, as we get to that common hepatic. As far as the ostium, I think you may be right. I'm prepared, and it'll be a little bit tricky because of the hang-up, to put a Viabon, a smaller Viabon, and then more proximally, if we can engage it, put an ICAST to sort of bring us up to nominal at the ostium and get the support that we need. So I think that's all really good. We'll see how it goes here, of course.
Let's get the
Just one question.
tool to make a.
Yeah,
Yes.
sorry.
Yeah, the
Just
tool.
one technical question. You're going to coil the splenic artery, or you're going using a plug?
Not the tour.
Because this is, from my opinion, it's a little bit more, I would say, easy and safe.
Which, the
Do the
plug or the
vascular
coil?
plug.
Yeah, the problem is working from the radial. We're actually going to try to get the reverse medical or AVP people in here. We don't routinely use that, and we had a little difficulty
it does.
coordinating that. So we're planning to do some interlock coils here. You know, and the problem with the plugs is they're a little more rigid. You need to get a larger sheath across unless you use the AVP4, which will go through a 35 catheter. You know, I like that idea, but be perfectly honest, just didn't quite pull it together today. So we'll use interlocks, and again, very comfortable with the interlocks. And what I'm actually thinking here is that once they get into that splenic, I might actually bring the Viabon in, and that way it'll be protected, and they can just sort of coil, you know, with the Viabon in place, and you should be able to easily get that out. So
Need a torque.
once they get that splenic, I'm going to go ahead and kind of load the Viabon, and then they can coil with an occluded state. We won't have the benefit of showing that we have flow occlusion, but we'll get a dense coil pack and have confidence that we've occluded retrograde filling into this. So just give them a minute here to do their job. And it's funny, it popped into the splenic off camera. Obviously now that we're on camera, it doesn't want to behave the same way. Some of that may be that our wire in the hepatic is changing this morphology a little bit. So. Let me get you some sort of oblique here. Obviously, you know, the plan sounds great on PowerPoint, and then implementing this component of it can be a little challenging. Especially once we have this wire and we've straightened out now the communication between the celiac and the hepatic. I think when we sort of started, they had the wire in the splenic, and obviously on camera we're trying to move quickly with both wires.
Yeah,
So you can't just get a regular glide wire?
Hard to get a wire out through all that tortuosity.
Yeah. I think that we're going to get a regular glide wire here. I think this is going to work pretty well. I mean,
All right.
So, John, as you're working there, what is your wire going to be that you're going to wire and put your Viabon over? What type of wire is that? Is it an 018 wire or is it an 035?
Yeah, we already have an 018 Platinum Plus out there. That's out there already. I already made that exchange. As you were watching, I brought out a glide catheter. Again, the morph is working nicely for us here. I think we have a good secure guide position. And once I have the glide cath out, I have a 260 018 Platinum Plus wire.
And is that a 6 French morph or an 8 French?
6 French morph.
That'll limit your Viabon to what, a 7?
It'll limit our Viabon to a 7. Yeah, and it's an 018 system, so. We're so close to Nirvana here, we just sort of have to get this to. There we go. Okay, excellent. Nice. All right. Good job, Dr. Patel, Dr. Herman. I don't know who did that, but so when we bring our catheter out, and when we go ahead and get our Viabon, I think we have a 760. Mm-hmm.
No, it's not going to track. We just need to track a little bit.
You get a little extra wire. What catheter do you have there?
This is a seroradial catheter.
Okay. So they have a seroradial catheter
you get
here.
that enough. It should be enough.
We've
to now
been
get
picking up our experience with transradial interventions for a variety of things. Not as much for peripheral arterial disease other than iliacs.
Now
I mean, there was a big push for that, but I'm not convinced. But certainly,
I think so.
What are you doing?
We're going to try to get that now, get the prograde back in, see if the wire goes right.
So,
Yeah.
John, can you tell us
Mike, we'll need that prograde back?
when you're going to coil a splenic artery, where do you want to put your coils? How far down?
Yeah, so it's proximal to mid.
I'm sorry?
Yeah, you want to be distal to the dorsal pancreatic and proximal to the pancreatic magna. That's your optimal
No, we're
location.
just going to coil through here.
For a, and certainly in the trauma setting, that's what we rely on. So you reduce the pressure head and you control, say someone who has a splenic laceration, you control bleeding, but you maintain splenic viability 100% almost.
And do you use retractable coils, and what size will you use?
Okay,
Yeah, so
back,
we use
Mike.
detachable coils, and looking at this, it looks like we're going to probably want some, you start bigger and then go smaller. So we'll probably start with some 6s to 8s initially, and then we'll sort of
we
fill
got 6s pulled
in
off.
the nest.
Torque.
So these guys, they felt they were in the splenic already, and they now are trading out to a microcatheter system. I wasn't so sure they were in the splenic already.
All it was advancing.
Yeah, so, okay. Let's go ahead and lower the Viabon on here.
Yeah,
Oh, six, get a six
yeah, do the
Viabon.
6 we have. 650s.
Yeah, so size constraint, we're going to get the 6 Viabon through. Even that, I'm a little worried that we may have to trade out here for a different sheath through the morph, because the morph does have a compromised ID. Yep.
Micro.
There you go.
That's a nice turn, yeah.
There we go. All right.
Yep,
There we go
okay.
again.
I got it advanced now, the micro.
All right. All right.
That's it, yeah. Should be.
So more and more, I'm liking my idea of, once we prove we're there, kind of trapping this in place with the Viabond if we can, because this looks like it's a tenuous position for the splenic, and I don't want the coils to start kicking out, right? So let me see how we are there. I want you to hook up and do injection.
CC merit, Mike.
So, John, you've got about, I just want to give you an idea of where we're at. We've got about 5 minutes of transmission. I don't want you doing this is a complex case you won't be able to finish at, but just keep us apprised of your thought process. This is a great case.
Yeah.
And just being aware, about 5 minutes, and then when we get closer, we'll just have you let us know what you're going to do to finish the case.
Right. Okay. Yeah. So we're actually got in the GDA there. So the big hang up here is getting around this splenic. You have 118. Once you get around the splenic, I already have this Viabond loaded. I'm actually going to kind of get it close. Be careful, don't pull too much wire, Mike, because we don't have that much purpose.
So from our German colleagues, are there any tricks you have for getting around the splenic? I hate the splenic artery. It's a hard thing to get a wire, as we're seeing here. Do you have any tricks?
It's a quotable quote. I hate the splenic artery.
But it loves you, just in case
I know,
you
believe
want
me,
to
they seek me out, and I don't like them.
Mike, let's get
What do you do?
another one of these.
I would
hold the
try
back
to,
of this,
to get the splenic artery from the ground.
one of
So
these wires.
from below. No,
Yeah.
with these.
With the
And
right.
first,
Torque with
first
the device.
splenic artery
We're ready to
embolization
go
with the
here.
plug, and then go for treatment of the hepatic.
You take an 014 wire deep out there, or do you take 035, and how do you?
No, 035 for,
fast.
should be okay, I mean, I think.
Here.
Glide wire or
Glide wire.
Turn,
Glide
we'll
wire.
be good to go.
Good. So once you do that, I get the micro in place, and I'll
Yep.
deploy. So I'm hoping we'll get this done in the next 4 minutes. So they're ready to make a quick turn here into this splenic and get their micro in place, at which point I've got a 6mm Viabond, which I'm going to put into the common hepatic. We'll go lateral, and we'll complete the ostium probably with an iCast, as Peter suggested. And then these guys can take all the time they need to go ahead and coil that splenic. So I'm hoping that we can get you a picture with stent in place in the next couple of minutes. Just got to hang this splenic turn.
Yeah, take your time. We're seeing exactly what's and we know what the result's going to be when you're done. It's going to look beautiful. So take your time and just show us the technique and talk to us.
And this 6 Viabond, I think, is a real nice fit. There, we've got splenic.
it.
Good. Micro down. We'll just confirm we're in the right spot. They're going to go ahead and
Let's advance a little more.
I'm bringing up now the Viabond. This is actually the
Make
morph's
sure.
working great, so we're up pretty good
3
here.
cc merit with contrast, please.
Kicking a little bit, but
Mike
not too
Wire.
bad.
Have other panelists had much experience with the
Thank you,
morph
sir.
catheter? I find it to be a tremendously helpful catheter with good support, and also helps an aneurysm gate cannulation. What do you think? Anybody else have experience with the morph?
All right. All right, a little bit hard to image through that.
Okay,
It's
so we're
extremely
in.
valuable as an all-around
coil
tool.
here
You
real
also
quick?
can use it to push and pull, and in all kinds of cases, EVAR,
go lateral.
TVAR, and
Go lateral.
you know,
Move your feet.
lost,
Mike, some more.
foreign body, endo
Good
junk.
stuff.
Any time that you're trying to move something around, you can use it as a hook. So.
Yep.
So let me deploy this for you here. So I'm going to do is going to go lateral here to get a sense of where we want to be. And looking at this, we can probably come back a little bit with this. So I'm going to do that. I'm going to bring it back to about here or so. And we're going to deploy this in this position.
Interlock.
Actually, I'm going to come back a little bit more so I don't have so much difficulty getting that ostial iCast. I'm going to deploy this right about here.
The Viabond there, right?
So that Viabond came nicely there. And I'm going to back this out. We will get a run, at least sort of see how we're looking at this point. And hopefully
Open up the coils. Yeah.
have a
Open
good
up
initial
the
picture so you can
620
sort of see where we're heading
cell.
with this.
Yep.
Hey, John, good news here.
Open up the coils. Yeah.
Have a
Open
good
up
initial
the
picture so you can
620
sort of see where we're heading
cell.
with this.
Yep.
Hey, John, good news here. Our gracious
Yes.
German hosts are going to give us 5 minutes more. And Michael Dake has agreed to say
get
we
those
want to see
coils.
this rather than do a talk. So take your time. This is good stuff.
Donkin.
There's no more filling of that
All
aneurysm.
right, so obviously you can see now we have the aneurysm nicely excluded. Can you stop that? Play that back.
We'll play it right
And
from here, Chair.
we're going to go to AP. Well, let me go ahead and let's finish up this ostium, I think. Let me have, please,
You need a 659 ICAST.
a 6 millimeter ICAST.
We can actually do, because it's by 80, so we can get the short 6, one a 622.
622 ICAST.
All right,
Yep.
622 ICAST. Bert, 622 ICAST, please.
What are we hitting that we're not rotating there?
And Peter,
No.
this was a strategy you were alluding to earlier, a balloon expandable
I want
stent to
the either
reinforce the
6
ostium.
by 20 or 22.
Right.
Does it need to
It's
be an
not here.
ICAST if
Is
you've
it?
already used an atrium?
I
Yeah,
don't think so.
perfect.
I think you could do it with a self-expanding nitinol stent. But the problem is the lengths. We don't have short
Hold your breath, sir.
lengths with reliable endpoints. So this is where a balloon expandable is helpful.
But does it need to have a covered stent? Can you use a renal
Do you need
stent
any
inside there
more
since you've already got a Viabon?
Oh, I got
get
you.
back to
I
this
think you
ostium.
could.
So we're going to get that ICAST loaded, and we'll bring it right back to the ostium. That's coming on now. Very good.
Can you open the interlock?
So it's a 622 ICAST.
620.
Okay, go ahead and load it. Yep. And then once we have control of this, we'll probably use the same balloon to, if we can, get into that Viabon and post-dilate that a little bit.
Remind me, it's getting close to the
my
cutoff. Does a
colleagues here to
6
coil.
millimeter atrium go through a 6 French sheath?
Yes,
Yeah.
we believe it does, yes.
The longer one goes through a 7.
The longer one doesn't. Here, all right, so we're coming up just fine here. Fine here.
You have an inflating device, please? You have one? Okay. We'll use that first one, that one, then the second.
Seems to be pretty good. I'm going to come off the oblique for a minute just to sort of watch transit of this. Make sure we engage that Viabon. So this is really nice. So that didn't kick the Viabon, so obviously that was our concern that we would engage that Viabon. Let's go back to this lateral. That's going to be a little bit tricky because of the lumen constraints of the morph to really see ostium. So I'm going to get as lateral as I can here. We might have to do a little inference job.
Yeah. That's the challenge of having arm access. Sometimes it's really hard to get that nice straight lateral picture.
Right. Okay, so I just pulled back our guide. Let's see if we can get some imaging here. All right, so there we see where we have to go. Let me mark that. Pen. Play that back. All right, so I'm just going to mark on here where we have to land this. We have a Tim's auto trace that Dr. Herman was instrumental in developing, but
We do. We have it ready for use, John.
I think that actually, looking at that last run, let's see the run back.
Replay, please.
I think that actually, a little hard to see the marker on that.
It looks like you need to come back, do we think?
Yeah, a little bit, I think. Yeah, right. So there. Now that brings me right to the marker. So we're going to go ahead and inflate this here. Okay. Thank you, Peter, for this suggestion. I think this is really the way to go here. 6. A little hard to see it deploying, but presumably it is.
We'll go to 8.
Yeah.
Nominal's 8 on that?
6.
Yeah. Let's go to 8 on that. That should be good.
All right, that looks like that's going to be pretty good. Now I'm actually going to come back and just do the ostium just a little bit more aggressive here.
So, John, as you're pulling it back and working, we've got about a minute and a half left. I want to thank your team there. You know, you did 2 cases here that were spectacular, 2 in the other room, and I know how much work. We all know how much work that is. So, to that, your entire team, thank you very much. It's been outstanding.
Hold this. Yeah, so we're going to get some good pictures for you here before we do that coiling. I think that this is going to really look nice.
So you still got your catheter trapped there. You're going to drop the coils and then just take it out when you're done. Is that right?
Exactly. I don't anticipate any problem pulling that out around. It's a microcatheter. Let's see how this looks. Hold your breath, please. Don't move and don't breathe. All right, it's a little bit hard to see. Let's get this up a little bit more. Like that.
There you go.
One more time. Hold your breath.
We'll get an AP.
Yeah, that looks really great.
Yeah.
And let's go up to an AP here. Okay. So, great. De-zoom this a little bit. Again, everything's nicely in position here. Hold your breath, please.
Very nice.
So that looks good. So we do have a little bit of filling around that. We're going to coil that splenic. Again, we're remodeling the celiacs. I don't think there's much more for us to do. We'll get some additional pictures at the end, but this obviously looks dramatically different than it did at baseline. Just go back to the first run and you can sort of see here we are now and how this looked when we started.
So I always wondered, do we need to coil that splenic?
All right, so there you go. The world's a difference, yeah.
Big difference.
Yeah.
So, John, that's
So we're going to coil that splenic so we don't backfill.
fantastic job by you and your team. Thank you all very, very much.